Thank you for having me. I'm excited to be here to share the strong model for geriatric care within Thrive, which is the HIV clinic of the Institute of Human Virology at the University of Maryland School of Medicine. This is a grant-funded project through Gilead Sciences, so my team and I are all receiving a portion of our salaries through this funding. There are no other disclosures. In the next 10 minutes, I'll quickly describe who we are, the model of care that we've built, and how. I'll go through a case example, and I'll end with a rundown of what's working well and what challenges we've come across. Starting with who we are, what's Thrive, and what's Strong. So the Thrive Clinic offers primary and specialty care to approximately 3,000 people living with HIV in Baltimore City. Jacques is our outreach partner, and our combined services are listed here. I won't read through the list, but if you scan the bullet points here, you'll gather that our aim is to provide the most comprehensive care possible, to keep our patients in one center for everything that they need, and to meet patients where they are by addressing their medical, social, and mental health needs. We're very fortunate to have extensive staff to meet those aims, including approximately 30 physicians, nurse practitioners, and infectious disease fellows, a strong social work program with a social worker for every patient, and assistance with housing, mental health, employment, and substance abuse for those that need it. We also have 5 pharmacists, a dietitian, and peer support coaches, and other staff as you see here. Moving on to the Strong team. This is a multidisciplinary team constructed of Thrive team members and experts in gerontology, epidemiology, and education from other schools in the University of Maryland, all with an interest in HIV and aging. The first year of this project was actually fully devoted to developing a plan and developing the model. The goals were to obtain patient and clinic input regarding priorities for older adults with HIV, train staff in geriatric principles, and identify available resources that can benefit people aging with HIV. And then to take what we had learned from all of this to introduce the geriatric assessments into clinical care at Thrive for people over 50 with HIV, and utilize that baseline data to determine geriatric needs and eventually assess the impact of the program. And finally, to disseminate the results in the model for an integrated geriatric HIV care model that could be adopted by other clinics. Gathering input included 2 patient listening sessions with some example questions seen here. Concurrently, we conducted provider input sessions to understand what gaps they saw in geriatric care at Thrive, get their ideas to fill those gaps, and also ask them to review our proposed model. Providers also did a pretest and a needs assessment on geriatric principles, and our nursing and social work staff took a quiz on biases related to age. There was also a lecture series for social work on aging topics noted here. And as a group, we saw local, regional, and national expertise and resources on HIV and aging. We became part of the Maryland Coalition on HIV and Aging, and several of us were actually able to come to this conference last year for the first time, which was really a wonderful opportunity to meet others in the field and further refine the model that we had been developing. And after all of that, we were able to decide what assessments we should be doing, what data we wanted to collect, and the logistics of all of that. So I will walk you through an overview of the final model and then go into further details on each part. Any eligible patient can self-refer by calling a phone number. They'll be scheduled for their assessment visit, and then they get a reminder call the day before. The in-person portion is done by one of our grad students, and that takes about an hour. This includes validated assessments of mental health, cognition, physical function, and quality of life, plus our own questionnaire meant to address topics for which validated data collection instruments don't exist. Participants receive a $25 grocery store gift card, and prior to leaving, they're offered follow-up appointments with their medical provider and a pharmacist to review those results. In the meantime, chart review is done by a medical provider and a pharmacist on the Strong team. All the information from the assessments, questionnaire, and chart reviews then goes to 3 places. It goes to their team, goes to medical records to be scanned into the chart, and into a REDCap database. Needed interventions are determined for the team, and they're at their discretion. We didn't mandate any particular intervention because we wanted to watch what happens when all of this information is handed off to the team so we could track what assessment results seem to have the biggest impact on care delivered. We do also have some money set aside for medical equipment that's not covered by insurance, and we've used that for things like canes and grab bars, and we also have a resource guide available to the team. Shown here is our summary results sheet for the in-person assessments. You can see under the cognition and mental health domain, we tested for depression, suicidality, anxiety, and cognition. For example, for depression, we used the Patient Health Questionnaire 9 instrument, and there's a place here for the patient's score to be recorded. In physical functioning, we did the short physical performance battery and the Older Americans Resources and Services score for activities of daily living. We did the Freed Frailty assessment and a nutrition assessment. And finally, the PROMIS score was done to measure quality of life. Most of these are questionnaires, but there is a small amount of physical activity, including a 3-meter walk, a sit-to-stand exercise, and grip strength testing, for example. The medical team would then receive all of this information with the abnormalities highlighted. And then we have this third column there to suggest possible next steps. For example, a high score on the depression or anxiety screen should be referred to social work, and evidence of frailty or weakness could warrant referral to physical therapy. The STRONG questionnaire was specifically created by our team to get at some of the major social and miscellaneous aspects of living with HIV that gerontological assessments might miss. This was largely based on input from Thrive, the STRONG team, and from those patient listening sessions, and this takes about 30 minutes to complete. This is the medical chart review. Major categories we look at are HIV, bone mineral density, cardiovascular risk, renal and liver disease, and cancer screenings. These were specifically selected to look at age-related comorbidities in people aging with HIV. For each section, we're recording the result, noting if the screen is up to date and when it is due next. Most of this is fairly straightforward. It's the cardiovascular risk section that's a little bit more complex to complete. This is all based on what has to be input into the ASCVD risk calculator, which is why the categories look oversimplified, like race as Black or white and sex as male or female. But here we record the smoking status, whether that patient has hypertension, diabetes, or abnormal lipids, and if they're taking an aspirin or statin. Based on the calculated ASCVD score, we then include whether the current guidelines recommend that the patient should be on an aspirin or statin, and would make note if there are any recommended changes. The pharmacy chart review is similar. They're looking primarily at medication reconciliation, including whether the list in the electronic medical record is up to date, how many prescribers, how many pharmacies, and how many medications there are, and if there are any dangerous medications or drug interactions, and they'll also take a look to see if there's evidence of non-adherence. The pharmacist would then fix those issues themselves as they go and notify the HIV specialist if there are any further changes needed. They'll often set up an appointment with the patient to review this and to educate the patient as needed as well. And this is just one example of what the final summary might look like once complete. So in red, the scores are written and are circled, and the highlighted areas are abnormal scores that we want to draw the team's attention to. For example, this patient had a high depression score, a low cognition score, difficulty with grooming, was considered to be pre-frail and at moderate nutritional risk, and had a low quality of life score. Based on this, each of these areas could be further discussed with the patient, and a plan could be made to address each. I'm not including the chart review case examples in the interest of time, but it would essentially be very similar to this portion. And this is a very consolidated summary of key points in one patient's social questionnaire. The patient was very close with our social work director, Robin, and had been working with her for over a decade. So much of the information on the form was already known, but there were also some surprises too. For example, this patient had never mentioned any housing concerns or sought help in this area, and had not been in a relationship to our knowledge for many, many years. However, in seeking assistance in housing through this questionnaire, a larger conversation opened up. She wasn't actually sharing the housing with a cousin as she had written. It was a male partner, and she disclosed that this was not a healthy relationship, and that's actually why she wanted help with housing to find other options to leave this person. So I'll end with some remarks on what seems to be going well with our model, plus some challenges. The first key factor in our success thus far is that the entire clinic really got this project. They saw that it was filling a major unaddressed need for our patients, and thus it's been very well received. The patients that did the listening session also really enjoyed that and actually requested that continue, which we thought was a wonderful outcome and could help address some of the social isolation issues noted in those same sessions. The participants that did this study, though this was a self-selected group that was earning $25, they did also tell our grad students that they felt this was worthwhile and they were happy to be able to have these assessments done. As I alluded to when I talked about the questionnaire, we found out a lot of stuff about our patients that we never would have had the time to ask about. I think the partial anonymity of filling out these forms with a grad student they had never met before really helped people open up. Our grad students also remarked how much the patients really enjoyed talking and sharing their stories. So I think that alone was therapeutic for some people. Of course, getting data is incredibly helpful as a clinic to better understand who our patients are, what their needs are, and to identify areas we should maybe be applying for additional funding to address. And I also suspect this will lead to various QI projects to try to improve areas that we find gaps. This project has also improved general awareness of geriatric assessment and resources. And we believe that there's great potential here to improve patient care. From a business standpoint, which is listed last for a reason, patients doing these assessments could also have multiple visits to do the assessments, to receive the results, and to get further tests or care that they need. In terms of challenges, there are a few, and they're actually, I think, very important. There were some logistical considerations which really took us a while to figure out, and obviously would be unique to each clinic attempting to do this. One struggle, of course, is if we identify a problem, we'd like to fix it, and some things are not fixable medically or within our resource constraints. So we struggle, for example, when patients have a low MoCA score for cognition and there's no reversible medical reason, is there are not really a lot of resources to successfully address cognitive decline, especially in a patient population with a lot of other social and financial challenges. The biggest challenge, obviously, is the question of whether or not this is sustainable when our grant ends. We currently have 2 half-time grad students to do the assessments, and the patients in part may be motivated to take part because of the monetary incentive. What happens when both of these disappear, I don't know. We've also found that it takes a really long time to fully review the results of these assessments with patients. This is difficult to do in a brief medical visit, so might require additional visits or longer visits, and there's always a question of how that level of care fits into the US healthcare system model. Part of our hope with the project is that the Thrive staff and providers will see the benefits of these assessments and eventually take it upon themselves to do them in the routine care of their patients. This is probably something that won't happen until the grant-funded portions are no longer available, so we won't know how this looks for another year or 2. And it goes without saying that COVID has thrown a major wrench into this project. We immediately stopped doing in-person assessments as soon as the pandemic started, but we are just about ready to resume, but only the portions that can be completed over the phone. So I'll end there, and I thank you for all your time and attention and for having me here today. This is a picture from last year's conference, and in the middle are 4 members of my team that, as I said, this was the first time we were able to attend, and this was right around the time that we were finalizing and refining our own model. So thank you again.